Hi, I'm Lindsey Smith, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. With nearly 1 in 10 newborns in the U.S. requiring care in a neonatal intensive care unit, and recent data showing that number is rising, the importance of NICUs have never been more clear. These specialized units are lifelines for the most vulnerable patients, delivering highly advanced, around-the-clock care in some of the most critical moments of life. On today's episode, we're shining a light on the extraordinary world of NICUs with Lindsay Howard, a veteran NICU nurse with over 17 years of experience caring for premature and critically ill infants in high-pressure environments. Lindsay has served as a subject matter expert in nursing education at Elsevier and currently works in a Level IV NICU at Children's Memorial Hermann Hospital in Houston, Texas, one of the most advanced neonatal units in the country. Her career spans major hospitals in New York City and Houston, and she holds multiple specialized certifications in neonatal intensive care nursing, neonatal and pediatric resuscitation, and pediatric chemotherapy and biotherapies. Outside the hospital, Lindsay is just as busy. She lives in Houston with her wife and their energetic 6-year-old twins and 2 dogs, balancing a full family life with her deep commitment to neonatal care. Thank you so much for joining us today, Lindsay.
Thank you for having me.
So let's get started with learning more about you and what got you first interested in nursing.
Well, I am the oldest sister in my family, so I have 2 younger brothers. And when my middle brother was born, he got sick. I was 4, so the details are fuzzy, but I do very specifically remember going to visit him at the NICU because he came home, got readmitted, and was there maybe for like a week or so. But I remember going to visit him and seeing him in the NICU, like seeing him through the glass, and the nurses were so kind to him and so kind to me, the big sister who didn't know what was going on, but that really left an impression on me. And, I like to play with dolls and, all that stuff growing up. So I was like, oh, I'm taking care of, the babies, like the nurses were taking care of my baby brother. That's kind of how it started, I think. And then, as I got older and was like, what do I want to do with my life? That always kept popping back up.
Awesome. Thank you so much for sharing that personal connection. I'm always interested to hear how people get started. And it's clear from your personal connection there that those nurses made a big impact on you and probably an impact that you're making on other people today as well. So you went to nursing school.
Yes.
And then can you talk about what led you into that pediatrics and critical care part?
Well, again, like I said, I was the oldest sister, so I was always around kids and younger kids. All of my jobs growing up, I was a babysitter. I worked at the nursery and the YMCA. In high school, I worked at a art studio for children. So I was just always kind of with kids. And I knew that I I wanted to keep focusing on them. I always got along really well. It was always easy. Adults are messy, as we all know, and trying to put all that together, it was always a no-brainer for me. I very specifically, if I wanted to do nursing, I wanted to work with the littles, my chosen population.
So today you work in a level 4 NICU unit. Can you talk us through the different levels?
Yeah, so the neonatal levels of care are determined by the Texas Department of State Health Services. And so they go from 1 to 4. 4 being the most severe, most critical, 1, being the less critical, maybe just some full-term infants who just need like a little bit of extra support for, a transition period. Level 2 NICUs really don't take care of younger than like 32-week gestation and then up from there. So then 3 is kind of like a little bit more sick, and then 4 is like the most critical, the most severe, the most complex cases that need 24/7, not just neonatal care, but also access to, pediatric surgery 24/7. All those specialty teams that you find are always there on site in the level 4 NICU. It's not like a doctor's, at home and needs to be called in. There's always those surgeons, those specialists, neonatologists there 24/7.
That's a really helpful breakdown, and understanding the different distinctions between those different levels gives great context to the complexity and intensity that your team and you provide. I'd want to dig a little deeper into kind of what your day to day looks like.
So I actually do 2 roles in our NICU. First one is like my standard, NICU nurse bedside role. So you, as a nurse, would take care of anywhere from 1 to 3 babies, depending on acuity. So if you have three, they're pretty stable, maybe just like former preemies that are still learning to feed and just growing and just kind of like getting closer and closer to that going home point. Versus if you only had one, that would be a very sick, very critical, needs like one-to-one attention all shift long. So just depending on where you are that day, our NICU is huge. Our census likes to hover in like the 130s, 140s, which is a lot of babies. And so therefore a lot of nurses. And you never know what you're coming into. You could be coming into that really sick critical assignment, or you could be coming into like a 2 to 3 baby, just working on some feeds and trying to help get the family ready for discharge and that kind of stuff. So there's that. And, the general, like, there's general baby care, but then also like the stuff, obviously, you would have inpatient, like labs and the medical team rounds, and they're changing orders and changing fluids and doing all those things, consults from specialty teams, diagnostic imaging, and more lab work, all of that in 12 hours. So I do that. I also am on our central line team, which is a specialty team of nurses that deal with central lines. So like PIC lines, Broviac lines is a kind of like central line in the chest. But what they found through lots of research, some of which was actually at our hospital, is that when you have a specific group of people that are just dedicated to accessing the lines, maintaining them, dressing changes, inserting them, when you have a small group of people, you can really do good quality control. And so that leads to less central line infections. Nobody wants that, obviously, as a patient, as a hospital, as a healthcare system. And for babies, it's, an even bigger risk because they have no immune system. So a central line infection can really, really be bad news. So when I am on our line team that day, instead of being at the bedside role, assigned from 1 to 3 patients, I'm all over the unit, going to all the central lines, doing dressing changes, giving medications, changing fluids, helping with insertion. I just kind of bop around all day long. So my shifts are split up between those two roles.
It sounds like a lot of variety and also very demanding throughout the day.
Yeah. It keeps it interesting. We're never bored at work.
No, that's good. That's good.
There's always something.
So let's talk about some of the misconceptions about NICUs and anything that you'd like to clear up there.
Yeah, I think, less so in the medical field. Well, it does happen sometimes, but I've found throughout my time that like people think if you're a NICU nurse, you're just like holding babies, changing diapers, feeding babies all day, which would be great because who doesn't love to hold a baby, and cuddle with them. And sometimes, when we do have those less sick babies that are just going towards discharge, you do get to do some of that. But the NICU is really an ICU, and I think people don't realize that. It's just like the adult world with all the ventilators and special pumps, ECMO, like life-saving bypass, 10 medication pumps at a bedside, like all that stuff for a tiny human. So it's less cuddling and fun times, though they do happen, and more, serious critical care, critical thinking, use all your skills, get everything done, get the best outcome for your patient and their family.
That's a really important clarification. How has delivery of care changed in NICUs in the recent years?
It's interesting because when I first started, the what we call like viability for a fetus, which is where they can typically survive outside of the uterus, was about 25 weeks, which is still incredibly early, when you consider that a full-term pregnancy is 40-ish weeks. 25 weeks is still early. But now we routinely get babies that are 22 weeks, which is still crazy. And they're, like 400 grams, less than a pound. Very, very tiny. And I think that has obviously just come with, advances in medical care from the maternal side, taking care of moms with high risk complex pregnancies, getting them closer to that point where they they could deliver and hopefully bring their baby home. But there's still limitations because, like I said, they're 400 grams. And, like our smallest breathing tube is a 2 French, which, may not mean anything if you're not medical, but like literally a straw, a tiny straw. And that's the smallest, like literally the smallest one they make. There is nowhere that manufactures smaller. So if you can't get that breathing tube in, then, we're limited by sometimes those physical product things. If you can't get IV access with the smallest catheter, you can't resuscitate and help that baby get bigger and, a little further along the line. So we joke about like there are probably going to be robots one day in the NICU, or like they've done some studies. I don't know if you've seen with like, I think it was with sheep, they made like a fake womb, a fake uterus, and like a sheep survived in
Mm.
there. So I don't know how long that would be in the future, but I feel like, I don't know, maybe it'll come one day.
Who knows? Yeah, who knows? It's kind of exciting to hear about innovation and how things are constantly evolving. The 22 weeks is mind-boggling to me, and the stakes are so high, I think, at that point. I wanna talk about kind of coming back to the level of stress and how family members are going to be dealing with an incredibly high level of stress if their babies are in the NICU unit. How do you deal with that and the emotional dynamics of your work day to day?
Well, it can be a lot. I think you have to have good boundaries, strong boundaries, because being empathetic is obviously part of nursing. You don't want like some cold nurse who, just does the things and leaves, you there alone while your baby's in this box and you don't know what's going on. But at the same time, you can't be the nurse that's like falling apart when, something sad is happening, something stressful is happening. Like you have to be on top of your stuff. And so you have to be able to turn that off, that emotional part off for a little bit to focus and do the stuff that needs to be done. I'm pretty good at that, so that works well for me, but we do have a lot of stuff in place at work that helps. A few years ago, I think probably after COVID, actually, and all of that fun, they came up with a code lilac, sort of playing off of like, you see it on like hospital shows, like a code blue, a code this, but a code lilac is for the healthcare workers when there's been maybe like a death or sometimes like a cluster of deaths or just like really stressful time. And it's usually led by like the chaplains and some of our nursing management and some nurses that have had extra training and like not grief counseling, but just like supportive communication counseling kind of stuff. So they'll hold those after a rough shift or after a rough time. And it's just kind of a place where you can go and like debrief and like talk about how you're feeling if you want to do that. If you just want to sit there and be quiet, they usually have like lower lighting, and you can't have candles because it's a hospital, but like little fake candles and like aromatherapy and stuff and little activities, I think, that are supposed to help you, unwind and
Nice.
process and all those things. Yeah.
Yeah, so maybe to play that back, you'd help deal with some of the stresses that you faced at work through having clear boundaries,
Hmm.
really striking that balance between being able to continue to do your job, maybe even compartmentalizing what's happening,
Yeah.
and then maybe leaning into some of those workplace resources, which are very helpful.
Yeah.
So, thank you so much for sharing that. I think that's a really good tip for all of our healthcare providers as well. I want to come back to something you mentioned in your last response, COVID-19. You were in the NICU during the height of the COVID-19 pandemic. What was that like, and how did your team handle changes that had to be made to family visitation and other policies?
Well, yeah, like you said, COVID was awful for everyone, I think, in healthcare. Super stressful, lots of unknowns, lots of product shortages, reusing masks, things like that. I think, in the NICU are fortunate that we weren't quite as frontline as like the ER, the ICU folks, because that was really extra crazy. But we also kind of call ourselves like the ER of the neonate world because we're never full. If a mom comes in and a baby's coming out or like something's going on, we can't be like, no, sorry. Like we have to take them. We have to make space. You never know. Anything could come in off the street in Houston, biggest medical center in the world. Like, we see all the things. So there was not as much, but some of that frontline stress. And luckily, I mean, most of the babies that we had that would be positive ended up pretty well. It was mild for them, which was good. But it wasn't always the case with the mothers. Pregnant women and COVID is a big, I think, a lot of people brush it off, but it really had some, devastating outcomes sometimes. So we would have a baby and maybe that the mom didn't survive. And so the baby's doing okay, but now you have the family also that we're taking care of who just lost their daughter, their wife, all those things on top of the COVID, like on top of all the regular stress that everyone had. So that was also part of where visitation would come into play because we had to limit the number of visitors for our safety, for the patient's safety, for their safety, frankly, the visitors. And nobody wants to say you can't come visit your baby. But also, if you have COVID or if you've been exposed to COVID, you can't come in our ICU. So that was tough. But what they did, which like I think they did a lot of places, was we had, iPads where we would do our best to facilitate Zoom calls, with an incubator and families at home. And I'm glad we could provide them with that resource, but it was also just more stress for us because, again, so our census is 140. We didn't have 140 iPads. We had like 5. I don't know. Zoom is much more like, obviously, here we are right now. But like in the beginning of COVID, it was still kind of a newer thing. And people who weren't using it for the workplace weren't super familiar with it. So like trying to help a family set that up over the phone from home and they don't know their email login, all this stuff. But meanwhile, like you still have to do all your nursing care. So it was a lot. I'm glad it's over.
That must have been a really challenging time. And to your point of giving them that gift of being able to FaceTime or Zoom in or see their little one, I'm sure meant the world to them. But it just added on to your already, you're so busy already at that point. So I can totally see that point. And I actually had my youngest in March 2020. My youngest was born on March 2nd. A few days later, the world shut down. And so I just snuck by with having visitors and whatnot. And we knew things were kind of happening and things were progressing. We didn't know how quick, but I remember trying to get out of there as quick as we possibly could because we didn't really know what COVID-19 was at that point.
Like I said, we weren't on the front line, but there was so much unknown and so much about how does it spread, to what extent. And I would come home and change in the garage, take all my clothes, all my shoes off, run to the shower, like it was a lot for everyone.
Yeah, for sure. So I want to switch gears a little bit. And as I noted in the introduction, you earned a specialized certificate in administering pediatric chemotherapy and biotherapies. Can you talk us through what's involved in that work?
I mean, to get your certification, you need, a certain number of years of experience. There were a handful of content classes I went to in person and online, skills labs, and then, taking a certification test to prove that I, I knew all this stuff and could administer it. But I feel like that's just something that's come along with the advances in medical care that we've seen these past few years is, babies that maybe have some kind of tumor or something that they find prenatally may not have made it in the past, may not have made it to delivery, but now they are. And also kind of playing into like, how do we say this? Restrictions on women's health care and, choosing when to terminate a pregnancy that may not be viable or, really complicated. And now they don't have that choice, especially in Texas. So now we have this very complicated, very sick baby that we can take care of. But so all of that to say that we see it more often now because we see babies that we may not have seen before with these very complex diagnoses being born with tumors that are cancerous and that need chemotherapy to try and either get rid of it or, just give them more time with their family. So previously, you have to have this certification and also chemotherapy is very probably know like has to be specially handled, especially administered. You can't just like give it in a regular IV. So you need central line access, which is where like our central line team comes in. A bunch of us got chemo certified so that we could administer chemo through the central lines because we're the only ones that can access it. So previously, these patients may have had to go to like a pediatric unit, but they still need that neonatal care. We're able to keep them in the best environment with the teams that really know neonatal stuff and give them the chemotherapy and biotherapies that they need through their central lines or through like implanted ports if they're big enough.
So, just coming back to the chemotherapy part, how young of a patient have you administered chemotherapy on?
Newborns, it'll take a few days. Sometimes they come out prenatally. They know they have this tumor or this diagnosis. And so usually there's like some surgical debulking that's done beforehand. And then that needs to heal for a couple weeks. And then they can start chemotherapy. There's a higher risk of different kinds of leukemia with trisomy 21 patients, so Down syndrome. And so sometimes we get those babies, maybe they have a cardiac issue, maybe they have something else, and then in their lab work, we discover like, oh, your white count is through the roof. And then we, consult hematology, oncology, and you find out like, oh, it's actually leukemia. So, I mean, literal newborns, like a week or two old, which is crazy. So again, sometimes the families know going in and sometimes they don't. So that's a lot. Like you just had a baby and oh, by the way, they also have cancer and need chemotherapy.
Immediately. Yeah.
Yeah. If you want them to live and to have the best shot at living a longer life, going home with you, we have to give this extremely caustic, extremely harsh therapy. So it's a lot.
Yeah. It is. I'm sure there's the stress part of it, the challenging times to go through, but to talk a little bit about like the rewarding parts of your job and why would someone consider being a NICU nurse and what makes the role so special?
I mean, I think that, the greatest reward and always the ultimate goal for us, obviously, is to get these babies home with their families. Nobody wants to be in the NICU, unfortunately. Like, we love it and we love being there. But families, everybody wants to go home with, their chubby, healthy baby. Nobody wants to be in the NICU where they can't have their baby at home. They may not be able to hold their baby, all that kind of stuff. So anytime we get to send someone home is always great. But a lot of times they also come back and visit us, partially because we have specialized like developmental follow-up for them, but also just because they like us. And you really become like family, that you didn't plan on having, but here we are.
Right. They've bonded. Yeah.
They, bring them back and we get to go out and see them all, healthy and thriving and doing like their normal baby things. That's super rewarding. And I think everyone loves that every time. And even now, like if we can't physically see them, sometimes, they'll send a certain nurse pictures and that nurse will go around the unit and be like, oh, look at, baby so-and-so. Oh my God, they're 3 now. They're doing so well. It's really makes you feel like all of that hard work, the stress, the long days, like all of that is ultimately for that goal to get these little guys home with their family. But what I also love about the NICU is that it's super niche, right? And you really need a specialized set of skills, mostly with your like assessment, right? Because babies can't tell you where it hurts, how it feels. I'm having trouble breathing. They're just there. So your assessment skills really have to be on point to catch all these little vital sign changes, all these things. I am super detail oriented, and I feel like if you like to have some control and some type A detail situations going on, the NICU is a great place for that because you have to be. Because when you have a 400-gram baby, the doses for things are in micrograms and you're measuring things in millimeters. Like the attention to detail has to be there. So if you thrive in the details and high stress sometimes situations, the NICU could be a great place for you.
It's such an important role and job to have and such a meaningful way to support the families and the babies at the most important time probably in their entire life. So thank you for all that you do there.
Sure.
I want to talk a little bit about your personal
Oh boy.
story with your high risk pregnancy. And so you had twins and they ended up needing NICU support.
Yeah.
Can you talk about that experience and how it affected your perspective on neonatal care?
Yeah, we always joke in the NICU, like, it's the NICU curse. Like, of course, I had the high risk pregnancy that needed all the follow ups and all the stuff in the NICU stay. But I feel very fortunate because we were in the best place. I would not have had them anywhere else. I know that where we are has the best neonatologists, the best nurses. I work with them every day. So I was very comforted by that. I think the rest of my family was off freaking out, but it's like, no, that'll be fine. We got this. It'll be great. It is still stressful. So one of my twins was there for a day, and then one was there for a week. So that was challenging because it's hard to be in two places at once. And luckily, my mom was here, had already planned to be here just for like postpartum, twins, you have two babies, like you're going to need help. So luckily, my mom was here so she could have the twin that went home and I could spend time with Rory. Our daughter was there for a week, still going back and forth. We would go see her during the day and then like, oh yeah, we still have another newborn at home. Like it's crazy. Come home and see her brother, feed him and do that kind of stuff, pretend to sleep for a little bit and then go back in the morning. I feel like I already was pretty empathetic for our families, but being there myself really kicked it up a notch, especially having my wife, as you know, is not medical. It really highlighted a lot of the gaps, in our teaching and our communication with families because I know all these things. I've done this for a long time. She has no idea, and most families have no idea. So they'd say something. I was like, oh, yeah, that's fine. She'd be like, what? What's going on? Like, why is he making that sound? Oh, yeah, you don't know. So just like further reinforcing how important that education is for families and also like re educating because as we've said, like it's super stressful. You're focused on your baby, you're focused on yourself. Like, hello, just gave birth, or your partner, whatever. You're not going to have your whole list of questions ready every time that the doctor comes and you're going to forget stuff. So I feel like it really highlighted the importance of our, revisiting, like I said, education and communication and really trying to keep, like, that family-centered care at the forefront of what we do.
Yeah. Well, thank you for sharing that personal story with us. And we're sorry that you have the NICU curse, but we're glad to hear that they're now thriving.
We always tell families, like, they won't remember this, so you will, but
Yes,
just get through day by day, take it one day at a time. The sun will rise tomorrow, we will get there, and one day it'll just be like a blurry, terrible memory. Hopefully not that bad, but, nobody wants their child in a hospital, so
for sure. So I want to pick up on that education piece that you talked about a little bit and how important that is. As you know, Osmosis, we're a teaching company. We love to fill knowledge gaps. Is there a topic you think Osmosis should make a video about to fill a gap that is of particular interest to you?
yeah, I have looked over the Osmosis NICU and newborn offerings. There's a lot of great content on like physiological processes and disease processes, but a big part of a NICU is developmental care. And that's very obviously specific to infants and newborns and the things that we do to try and give them the best development outcome neuro wise. Obviously, like as a fetus, you are in the dark, you're in fluid, sound is muffled because you're inside a human, all these things that we replicate as best we can in the outside world, but it's not the same. Our incubators are heated and they're humidified and they're covered in dark. The ways that we position them, there's special products that we use to keep them, we say it's like midline, like keeping your extremities to the middle of your body. Because again, they're used to being in a uterus. And so, like, when they move around their arms and legs, they feel those boundaries of the uterus. And that's just part of like human development. And you're like, oh, you get that feedback, whatever. But if you're just in an incubator flailing in the world, that's terrible for your, that neurofeedback for your development. So we try to keep them contained with all kinds of products, straps, bean bags, all this stuff, specially made for neonates and Also, just in the way that even we do our jobs with them, a big part of the NICU, we do what we call clustered care. So we try to bother them as little as possible, which is sometimes hard. But then when we do have things to do, we try to do it all at the same time. So it's just like one, I hate to say stressful, but it is stressful for them. One stressful interaction or like high feedback interaction where they're, getting repositioned and their diaper changed and like vitals and maybe some labs. Try to do that all at one time and then leave them alone for as long as we can so they can get that rest and development that they need as humans. I feel like I didn't really see any content on that. It's very NICU specific
Yeah.
again, but it's a big part of the NICU. And I think if you're not familiar, then you would have no idea. So
No, I think it's a great suggestion, and we'll certainly pass that along to our content team. We'll keep you posted if anything does get created there. So, also at Osmosis, we do have many students and early career health professionals in our audience. And I wanted to ask you, what advice would you give them about meeting the challenges of this moment and approaching their career in healthcare?
it's a good question. I feel like, like I said earlier, I always knew that I wanted to do pediatrics and babies. And there's nothing wrong if you don't know what you want to do and you want to, try different things out and see where you land, see what feels good. But I think there's also nothing wrong in like knowing what you want and knowing what you want to do. Like I knew I wanted to do this and I did it. All my rotations and like nursing school where I would choose pediatric populations. Like I did my community health rotation I did at a school. So I was a school nurse, things like that. There used to be, I feel like, a lot of chatter about, oh, you need to start in like basic medical surge and then like fine tune. But that's really not true anymore because, like I've said, the NICU is very specific and there's so much in the adult world that doesn't apply to us and vice versa. So I think my advice is if you know what you want, like really know, then do that and stay on that path and don't feel like you have to try everything out or dip your toes in everything. Like if you want to, cool. But if you don't, I think there's nothing wrong with following what you want. And then also, just finding other opportunities related to that field. So like in my case, pediatrics, just volunteering, kid stuff. So, I feel like the more comfortable you are with your patient population, the more you know about them, the more you can relate to them, not just in like this specific clinical setting role, the better the resource you are for them and the better healthcare provider it makes you as well.
So, get exposure early if you know what you want to get into. Find those opportunities to make sure it's a good fit. I know our listeners will appreciate your advice. So, thank you so much for sharing that, Lindsay. Thank you so much, Lindsay, for being with us today.
Thank you so much for having me. It was great.
That wraps up today's episode of Raise the Line. A heartfelt thank you to Lindsay Howard for joining us and sharing her deep expertise, compassion, and perspective on the critical role of NICUs. Her dedication to caring for the tiniest patients and educating the next generation of nurses is truly inspiring. We're grateful for the work she does every day to support families and improve outcomes in some of the most challenging moments of life. Thank you again, Lindsay, for being with us and everything you do to raise the line in neonatal care. I'm Lesley Smith. Thanks for checking out today's show. Remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.